All right, I think we're going to go ahead and get started. I think we have a quorum that we can begin with. I think it'll be an intimate group this afternoon. I'd like to start off by just introducing myself. My name is Suneeta Senapati. I am one of the reproductive endocrinologists and fertility specialists at the University of Pennsylvania. I co-direct the fertility preservation program there and have worked very closely with several of the pediatric oncologists, and I'm thrilled to be here today to talk to you guys a little bit about female fertility innovations. Despite the complexities that this year has brought with respect to clinical care and research and life overall, scientific progress and innovation continues in full force at Penn, and I'm excited to share a little bit of that with you today. I have no relevant conflicts of interest to disclose. I will also mention that throughout this talk, I'm going to discuss female fertility from the perspective of biologic sex assigned at birth. And importantly, the concepts and treatments outlined here are completely independent of gender identity and sexual orientation. So they really apply to any scenario in which a person is born with ovaries and a uterus. So if there are questions along the way regarding applicability to more complex scenarios, I'm happy to address any of those questions as well. So on another note, I always like to begin these conversations with my contact information in the event that you do have any follow-up questions. So on this slide is my email address, and I'll show it at the end as well. So please feel free to reach out to me if you guys have any additional questions. So to give you an overview of what's going to come into play in this next half hour, we're going to start off by discussing current trends in brain tumor incidence and how that relates to family building in the future. We'll talk about some of the basics of female fertility and how this applies to neurologic conditions. And then we'll review the options for fertility preservation and fertility treatments that are available, with the focus on those that are really most relevant to patients that have a history of brain tumors. As with any medical decision, major or otherwise, there are a multitude of factors to consider in making decisions about if and when to pursue fertility treatments. And finally, we'll run through a few clinical case scenarios to highlight some of the nuances of clinical management if we have time. These next 30 to 45 minutes are really for you. So we've left some time for Q&A at the end, but feel free to use the chat if there are questions along the way, and I'll try to pause along the way if needed. So to start off with, current trends in pediatric care demonstrate that brain tumors are a significant proportion of childhood cancers. And this diagram on the left shows some of this national data, particularly amongst patients under 20. This diagram that's on the right is showing the number of new cases of different types of cancer by age group. So the American Cancer Society estimates that there will be more than 89,000 new diagnoses of cancer in the US amongst adolescents and young adults. Most importantly, though, mortality rates are going down in both of these kind of patient care groups, suggesting that treatment is getting better and more patients are really looking ahead to life after treatment. So in line with this expectation, the American Society for Clinical Oncology is really encouraging doctors to talk to their patients as early in the treatment phase as possible about the potential effects on fertility and working to preserve fertility and addressing fertility needs in the future. In order for this paradigm to work, patients need to rapidly access oncology and fertility services, and also an interdisciplinary approach is really important to care. Now, so we are getting better at diagnosing and detecting cancers, which is great. And in addition, more than 3/4 of people diagnosed with cancer or a tumor under the age of 35 will live for many years beyond their cancer diagnosis. And so for many, this means thinking about the future and having a family. We've also seen a general trend around the world for various reasons. People are deciding to start a family at a later age. So 50 years ago, people would routinely have their kids in their early 20s, but now the average age of that first birth here in the US is 25 and older in some scenarios. So this has really challenged our field to look closely at how can we help people preserve their fertility and leverage the technology that we have for patients who have been through medical treatments and that may have impacted their fertility. So this has really given rise to this term oncofertility, which describes the many ways in which we can treat infertility or preserve fertility for patients with different types of tumors. So when we talk about fertility, we need to acknowledge that there are a lot of different pieces to the puzzle that need to come together in order to achieve fertility or to be able to achieve a pregnancy. And this involves this concept called the HPO axis. So HPO stands for hypothalamic pituitary ovarian axis. So in order for someone to achieve a pregnancy, there needs to be functional ovaries, functional fallopian tubes that connect sort of provide a conduit between the ovaries and the uterus and a healthy uterus. Most importantly, these organs rely on signals from hormones. These are molecules that carry information from the brain to the ovary. So in particular, there's a very small gland in the brain called the pituitary gland that releases some of these hormones that then gives appropriate messages to the ovaries to make the hormones that allow eggs to be released and also allow for a pregnancy to implant or stick on the inside of the uterus. So this schematic is basically describing some of these important neuronal and hormonal connections that are critical to an intact reproductive system. The pathway starts at the level of the brain with the hypothalamus. So the hypothalamus releases a hormone called gonadotropin releasing hormone, and that acts on the pituitary gland. The pituitary gland actually produces some additional hormones, follicle stimulating hormone and luteinizing hormone, and these are released in a cyclic pattern and act on the ovary. So the ovaries in turn then produce estradiol and progesterone, and the ovaries are actually where the eggs reside as well. So basically you need all of these hormones to be acting in this very complex interplay in order to get eggs to competency, or basically have the ability to achieve a pregnancy. In addition, this estradiol and progesterone balance changes throughout the menstrual cycle, and these hormones are critical to creating a receptive uterine lining, or the endometrium. That's the cell layer that grows inside the uterus, and this is what ultimately allows a pregnancy to implant and grow. So the second part of the fertility story has to do with the oocyte pool, or the egg pool. So in general, women are born with a huge pool of eggs, and this pool is actually the largest at the time that a woman is born. And so at puberty, there are about 300,000 eggs that remain in the ovary, and slowly this number decreases over time. And this happens in all women. And the average age of menopause, or kind of when that follicular pool is exhausted, is around 51. Now, we know that patients that go through different types of medical treatments can actually start to have a decline in fertility earlier because of exposure to different types of medical therapies. And in some scenarios, this rate of decline can increase as well. So the potential impact of these different disease processes on fertility depend on a multitude of factors. So for one, the cancer or tumor type is very important. The specific treatments that are involved are very important, whether those are chemotherapy or radiation. And also some of the effects that occur actually downstream from the treatment itself. So different types of chemotherapy can lead to infertility, and in some scenarios, early menopause. And some of the symptoms that people can experience from that include things like hot flashes, sleep problems, changes in their mood. There are also some long-term health risks, including osteoporosis and the risk of sexual dysfunction. So what about the effects that are specific to brain tumors? So there are a number of effects that are actually related to the brain tumor itself. So what we call direct effects of the tumor. And what can happen is the tumor can actually compress some of the cells that produce the hormones that keep this whole axis intact. This can cause menstrual cycles to stop in women that have already started to menstruate, or in very young women who haven't gone through puberty yet. It can actually prevent someone from going through those initial steps in puberty. Additionally, the treatment of these tumors sometimes is surgery, and so the actual surgery to remove a tumor or radiation that's directed at the tumor can damage the cells that make those hormones that communicate with the ovaries. I also mentioned that radiation can be a factor. So directed radiation, if it involves the hypothalamus or pituitary, can sometimes influence fertility. And if the treatment involves chemotherapy, there are some types of chemotherapy that are particularly toxic to eggs. So it's not all types of chemotherapy, but in particular, there's a group of chemotherapeutic agents called alkylating agents that can be particularly harmful to the eggs. So again, if a young girl is exposed to this before she goes through puberty, she may not go through puberty, or if she's exposed after, she may be at risk for going through early menopause. So again, reproductive effects depend on type of the tumor, the age at which somebody actually is diagnosed and goes through treatment, as well as the actual type of treatment that is involved, whether it is chemotherapy, whether it is radiation, and certainly the location at which that radiation is directed. So what can we do about this? So there's actually a number of options for fertility preservation and treatment. Some of these include oocyte cryopreservation, embryo cryopreservation, ovarian tissue cryopreservation. There may be some role for gonadotropin releasing hormone agonist therapy, although this is probably limited in patients with brain tumors. And then also, if patients go through treatment and have remaining ovarian function that's intact, there may be strategies for simply augmenting fertility with techniques like ovulation induction or in vitro fertilization. And finally, if none of these are options, there's also the alternatives of third-party reproduction, which include conceiving using donor eggs or in some cases using a gestational carrier. So I'm going to walk through each of these in a little bit of detail, and I'm actually going to start with oocyte and embryo cryopreservation. So this process really involves ovarian stimulation. So both oocyte and embryo cryopreservation start with that first step of ovarian stimulation. This involves a 2-week process of taking daily injections of hormones that can be administered at home, and it's usually combined with very frequent visits to the office for pelvic ultrasounds and blood work monitoring, usually about 5 to 6 visits over the course of that 2-week period. These injections that are given are usually a combination of follicle stimulating hormone and sometimes luteinizing hormone, as well as hormones that are designed to prevent your body from releasing eggs until we're ready to go in and get them, as well as a final step of oocyte maturation. So those are what we call the trigger shots. So those are some of the medications that are involved in this process. And then the blood testing is used to monitor levels of estrogen and some of the other hormones to help time when we go in and do the second step, which is the oocyte retrieval. So the oocyte retrieval is the actual surgery that's involved in retrieving the eggs. And importantly, when we do this egg retrieval, we're just extracting a group of eggs, the eggs that have actually responded to medical therapy. We're not taking out all of the eggs that somebody has. And then after that, there's basically 2 options that can occur. One is that those eggs can be frozen, or oocyte cryopreservation, also termed egg freezing. Or in some scenarios, if someone is going through this process at a later time and is either with a committed partner or planning to use a sperm donor, those eggs can be combined with sperm, fertilized in the IVF laboratory, cultured out to the embryo stage, and then frozen when they are embryos. So those are kind of the 2 main branch points, both of which start with ovarian stimulation. Now, this decision is usually based on the patient's age, what their partner status is, as well as a variety of other factors. Main risks of this procedure include bleeding and infection, and during the course of ovarian stimulation, the estrogen levels can get very high, much higher than is kind of in a normal physiologic state. In addition to this, in addition to kind of the risk of the medications directly, this can put some women at risk of getting blood clots in the legs or in the lungs. Now, oocyte and embryo cryopreservation, importantly, can only be done in patients that have initiated puberty. And also it requires that patients are in a reasonable state of health to tolerate this ovarian stimulation and egg retrieval process. So oftentimes patients that are very sick or already hospitalized may not be eligible for this type of treatment. So the pictures on the left are pictures of an ovary that were taken via ultrasound at the time of a pelvic ultrasound prior to starting stimulation. And then the image on the bottom is an ovary that is under the influence of the medicines that we use for ovarian stimulation. So as you can see, the ovary has gotten larger, and we can see these black structures on the ovary, which are follicles. These are fluid-filled sacs. Each fluid-filled sac theoretically contains an egg. We can't see the eggs because they're microscopic, so we actually use the ultrasound as a surrogate or substitute so we can track what's going on inside the body. Now, the actual egg retrieval is usually done by a vaginal procedure, which is done with the same type of ultrasound probe that we typically use for monitoring. And what happens is we attach a needle through this guide, and that basically helps guide the needle through the vaginal wall into the ovary, and we're able to remove fluid from each of these follicles that we've been measuring. That fluid then goes directly to our IVF laboratory, and so we look at that fluid immediately, and we can determine if there are eggs in that fluid. So theoretically, when someone wakes up from the egg retrieval, we can see how many eggs are retrieved. So in order to retrieve multiple eggs, I mentioned the patient has to be given a combination of hormonal medications to stimulate the development of multiple mature eggs on the ovary. And this process requires very careful monitoring with blood work and ultrasound, as well as coordination with the menstrual cycle. And I mentioned that there's a little asterisk here with respect to the menstrual cycle, because some women who have had brain tumors, they may not cycle regularly. Importantly, if their ovaries are functioning, sometimes the medicines that we can give can actually override the fact that someone is not getting a menstrual cycle on their own. So having a normal menstrual cycle is not always a requirement to go through this. It just means that the axis has to be developed enough that we are able to have ovaries that will respond to these medications. So each patient's a little bit different in terms of understanding whether or not they are in the right state to be able to utilize this technology. These are some of the medications that are often given for this process. Occasionally, it will involve a course of birth control pills, but that's more rare. It will also involve hormones that are recombinant versions of the same hormones that your pituitary gland makes to communicate with your ovaries. And these are some of the names of the medications that have been developed: Gonal-f, Follistim, and Menopur. Importantly, these stimulate your ovaries to mature more eggs than would mature in a given cycle. And most of these medications are given by injection into the abdomen, subcutaneous injections that you can give to yourself at home. The dose varies, usually taken for about 8 to 14 days. And then there's also a group of medications that are designed to prevent your body from releasing those eggs until we're ready to go in and extract them. Again, the egg retrieval, this is a different schematic showing how the egg retrieval is done, and basically involves placing a needle through the vaginal wall into the ovary to extract fluid. You are asleep for this procedure. It is an intravenous sedation that is given. Everyone is different in terms of how many eggs are retrieved, but on average, we tend to see 10 to 20 eggs in someone who is young and otherwise has not had any disruptions to fertility. Surgical procedure usually takes about 30 to 45 minutes, and then it's a same-day procedure, so you go home and sleep in your own bed. I want to fast forward through this and just show you a video here that basically shows a sample of what an egg retrieval can actually look like in real time. The picture on the right is one of my colleagues, Dr. Kalra, and we basically did a mock setup of what an egg retrieval might look like with all of the equipment. And basically she's looking at this ultrasound screen because this is what helps us to guide the procedure as it's done. Basically what you're seeing on this video is a needle being introduced into the ovary and into one of those black dots, which is a follicle that contains follicular fluid and an egg. You can see that that black dot is getting smaller and smaller, which indicates that we're draining the fluid from each follicle. Again, that fluid will go directly to our IVF laboratory, so we can in real time determine how many eggs are retrieved from the procedure. Now, importantly, there's still, debates about how the reproductive potential of oocytes that are retrieved from adolescents. What we do know is that ovarian stimulation can be done in adolescence. And so this is a table that describes a few of the cases that we've done in patients of various states. So the first column describes a patient with myelodysplastic syndrome who was 13 years old, who had actually not gone through menarche yet, but had gone through some of the changes that we see with the pubertal transition, including breast development, and also suggested that the hormone levels that we checked, including follicle stimulating hormone and another called AMH, suggested that she may be an appropriate candidate. So she took medications for 9 days and a total of 20 oocytes or eggs were retrieved. The second case was of a young woman who had a different type of tumor, and this was a germ cell tumor of of the ovary. And so she had had one ovary removed, had already gone through menarche, had already started to cycle, and we were successfully able to retrieve 8 eggs in that scenario. One of the other groups out of New York had also described a similar scenario of a young woman who had gone through ovarian stimulation. And then we also know that in patients that are slightly older, 19 and above, we are able to successfully retrieve eggs in that scenario. So we know that it's possible. And, well, importantly, I mentioned a lot of this monitoring that occurs is vaginal ultrasound monitoring. I think there's also a potential possibility for someone to have abdominal monitoring. I'm going to pause for a second because it looks like there is a question from our chat. And the question is, in someone who is 17 years old, when should she start the cryopreservation process? So this is a great question, and it really is something that's dependent upon several factors. One, I think it is about health state and when someone was diagnosed. So, if somebody has gone through cancer treatment already and is currently cancer-free, then theoretically this technology could be offered at any time. We most often see the scenario in patients that are coming to us having recently been diagnosed. So we're trying to capture the window of time from the time someone has been diagnosed to before they might go through any sort of cancer treatment, particularly before they receive chemotherapy. That's really the ideal time to potentially go in and retrieve eggs for that process. Theoretically, we may be able to do some types of fertility preservation after someone has begun cancer treatment, again, depending upon what type of cancer treatment they receive. So for example, if they receive a type of chemotherapy that is considered to be less toxic, we've had some scenarios in which people have gone through ovarian stimulation after this process or after their initial cancer treatment. Similarly, in the setting of a brain tumor, if somebody is getting directed cranial radiation and wants to complete cranial radiation, it is feasible to potentially go through fertility preservation after that, although some will go through before as well. A lot of it is a decision that's made in basically in communication with not just the patient, but also with her cancer team to really understand how much time do we have? Remember, it's about a 2-week time horizon to do ovarian stimulation. So this is always a dynamic discussion of, do we have the time to go through this? And then again, considering all of the other variables that we mentioned. Thank you for that question. All right, so another option for fertility preservation is ovarian tissue cryopreservation. And this is particularly relevant for patients that have not gone through puberty yet, or those who have a very narrow window of time between when they are diagnosed with their tumor or with cancer and when they need to go through treatment. So if for whatever reason, 2 weeks, we don't have that amount of time, then this is a very relevant option. Importantly, it does not require ovarian stimulation. What it does require is a minor surgical procedure called a laparoscopy. So the laparoscopy is where the patient goes to sleep, and we basically will introduce instruments through small incisions in the abdomen. And basically it involves removing a portion of the tissue on the surface of the ovary. Currently, this requires reimplantation of the tissue and the ovarian stimulation of that tissue at some point in the future. However, there's a lot of research that's being done to determine if we can take eggs from that tissue that's been cryopreserved and mature them in vitro or in the IVF laboratory. So that would potentially open up a whole other kind of avenue for patients to build families in the future. So basically, to describe what this involves, the pictures on the left show pictures from laparoscopy. These are pictures from one of my colleagues, Clarissa Gracia, who did some of the first cases at Penn. And basically what this shows is the picture on the top left shows this is the ovary or the left ovary of this patient. And basically with scissors and some graspers, we're slowly peeling a section of the top part of the ovary off. And then the pictures pictures on the right demonstrate these cortical strips. They're very, very small, and they're cut into even smaller pieces to be frozen. And then the pictures on the bottom are basically showing scenarios in which that tissue is then transplanted back into someone's body at some point in the future and may actually have its own function, may not need any stimulation to start working again. Or there are some scenarios in which we give the same medications that I described for the ovarian stimulation process for egg and embryo freezing to potentially stimulate this type of tissue in the future. Now, importantly, when I gave this talk about 5 years ago, this was actually considered an experimental treatment. But now there have been hundreds of children that have been born via this method. So this method is actually no longer considered experimental in adults. We're still learning more about the utilization of this tissue in the pediatric population. So again, ovarian tissue banking does not require stimulation. It is the only option for women who have not gone through, or young girls who have not gone through puberty yet. Its benefits are there's minimal delay in treatment. There's no partner needed at that juncture to make decisions. And in general, it requires surgical removal of this ovarian tissue. All of the births to date have been after orthotopic transplant. Of note, there is a theoretical risk of seeding cancer cells into the ovary in cancers that involve the ovary, so less of a concern for pediatric or adolescent brain tumors. This is a technique that does require multiple surgeries. And as I mentioned, there's still some ongoing research regarding in vitro maturation. I'm going to touch briefly on gonadotropin-releasing hormone agonist therapy. Again, it does have a very limited role in pediatric brain tumors, but basically the concept is that if someone is receiving chemotherapy, by giving the GnRH agonist before receiving chemotherapy, it may make the ovary slightly less susceptible to the effects of the chemotherapeutic agent. It does not require ovarian stimulation or surgery. It does have some side effects, including lowering bone mineral density. So this is somewhat of a more controversial technique overall. I'm going to pause for a second to take a second patient. And so the patient, this is a question saying that if someone has had a craneofaringioma removed at the age of 7, and then started medication such that she got her period at age 12, should she start soon? So in terms of fertility preservation. So this is a great question, just thinking about if someone has completed their treatments, is it necessary to go through techniques like ovarian cryopreservation? And I think that this is a conversation really dependent upon what is the surveillance that's happening with respect to a particular cancer, and what are the risks of recurrence or the need for additional treatments in the future. So if, for example, a patient has had resection of a tumor and has actually gotten their periods back and has gone through puberty, then ovarian tissue and ovarian stimulation for egg freezing itself may not be necessary. Now, if someone is not cycling on their own, as opposed to going through fertility preservation techniques, it may be that someone actually needs ovulation induction when they actually are ready to have a family. So that's a different paradigm entirely. So that is assuming that the ovaries themselves are intact, that they are normal, and that they have not been significantly impacted by any of the treatments thus far. But for whatever reason, meaning kind of prior treatments, if the menstrual cyclicity has not resumed in a normal pattern, then that would be a reason why someone might need ovulation induction therapies in the future to help them to cycle regularly so that they could become pregnant. So again, not every patient is going to need the full gamut of what we are talking about in terms of all of these options. And that's why it's a very individualized scenario in terms of deciding what treatment is appropriate and at what time. Luckily, some patients may not not require any of these at all. So if someone has has gone through puberty and has kind of resumed normal menstrual functions, then it may only be an issue, later in life if somebody is potentially having difficulty getting pregnant that they might need fertility treatment. But everyone's scenario is going to be kind of unique in this setting. And then the last thing I want to mention here is that fertility alternatives. So if there is a scenario in which fertility preservation or fertility treatment options for a given individual are not an option, either because, of their health status being such that they are not able to carry a pregnancy, or if, because of the delay in puberty, the uterus has not grown to an appropriate size, there are theoretically alternatives, including using a gestational carrier or third-party reproduction options in which someone can use egg donors or other methods to help build a family. Donor eggs can either be a family or known donation, so if someone who is specifically donating eggs to you. There are also anonymous programs around the country if you would need to utilize that technique. This can involve both fresh and frozen eggs. And I mentioned also separately from that, sometimes people have very good ovarian function, but they themselves cannot carry a pregnancy. And this is a scenario in which IVF can be utilized to freeze embryos that can then be placed into a gestational carrier who could then carry the pregnancy to term. And then certainly adoption is another option beyond that. New frontiers, I do also want to mention that a lot of the research that is going on right now is trying to augment fertility techniques and technologies that have already been developed. I had mentioned on the side of eggs, kind of figuring out if we are able to actually mature eggs in culture. That's a big kind of focus of research. Another is understanding the role of stem cell technology. So this has actually just been within, the past decade or so that this has really come into, gained a lot of attention. Of note, this is something that is still in its infancy in terms of development. But the thought process is that, there may be the option to actually take stem cells and use those to create very early stage eggs and sperm in the future for people who their gametes specifically have been impacted by different types of fertility treatments. So we may be able to take those gametes and then utilize them to help someone to have a pregnancy. So this incredible work is was actually pioneered in Japan. So in 2012, stem cell biologists in Japan were able to reprogram mouse skin cells into primordial germ cells by combining them with embryonic or non-embryonic stem cells. And then these cells were placed in the ovaries or testes of mice to mature them into competent eggs and sperm. And then using IVF and ICSI, live births were reported. Again, this is all at the level of mouse research at this time, but we're hopeful that this technology may provide an alternative to egg donation for some patients if chemotherapy in particular was harmful to the eggs. All right, so some of the factors that impact decision-making. I think, as I mentioned before, all of this is very dependent upon each individual scenario. So it's a balance of looking at what are the risks of doing these types of procedures, what are the costs, what are the chances of utilizing these types of technologies in the future, and then what is the ultimate kind of success rate that might be needed. Importantly, not every patient is going to need the full gamut of these or even each of these individually. So this is always a conversation that I encourage people to have as they're kind of starting their cancer treatment, but also sometimes it may be relevant in the surveillance period to meet with a reproductive endocrinologist to kind of talk through, all right, this is what I've gone through in the past. What impact might this have in the future? And what should I be thinking about as I am kind of proceeding with treatment moving forward? So individualizing counseling is such an important part of what we do. Again, factors that impact this include patient health, age and pubertal status, ovarian function, certainly the availability of fertility preservation options, because different centers, fertility centers will have different availability and expertise for some of these options, the cost of treatment and storage, and then certainly with any type of kind of newer innovative treatments, there's always social and ethical considerations along the way. I cannot emphasize enough how important a multidisciplinary approach is to this process. The last set of scenarios that I have are a couple of case scenarios that I just want to use to highlight scenarios in which it may be helpful to consider some of these technologies that we've discussed. So case one is a 16-year-old with a craneofaringioma who has regular menstrual cycles, but the treatments and kind of the results of her treatment have required that she's had very frequent hospitalization. So she's in and out of the hospital quite a bit. So this is a scenario in which ovarian tissue cryopreservation may be most applicable. It's possible potentially to do oocyte cryopreservation, but it's also possible that if she has regular menstrual cycles after all of this, that surveillance alone may be appropriate, meaning simply to monitor cycles over time. And we'll talk about some of the methodologies that are used for that. Ovarian reserve testing. So this is an area that we're still trying to learn how best we can apply this to the pediatric and adolescent population. Historically speaking, ovarian reserve testing was really developed for patients who were going through fertility treatments, who have been trying to get pregnant and weren't able to get pregnant as an adult. Some of those blood tests include anti-Mullerian hormone and follicle stimulating hormone. There's also the use of a pelvic ultrasound to count up the number of follicles on the surface of the ovary in a given month. This is called an antral follicle count. What we know about some of these, AMH in particular, is that AMH is produced by the granulosa cells, which are cells that support the eggs on the ovary. This level tends to stay relatively stable with the menstrual cycle. There's minor fluctuations, but overall it's fairly stable. And we know that it increases from birth and kind of peaks at the age of 25, then slowly decreases. So this is important because if we're checking these levels before the age of 25 in pediatric and adolescent populations, we need to take it with a grain of salt because we don't always know which way it's going to go, particularly if someone has gone through treatments that may influence their ability to get pregnant in the future. And most importantly, this is only validated to predict outcomes in IVF. At this point, this has not been validated as a true tool for predicting fertility in the future. Second case, we have a 24-year-old female who's amenorrheic after cranial radiation. So had a brain tumor in the past, had gone through cranial radiation. So this is somebody who, again, is not menstruating because of the effects of treatment, but actually the ovaries themselves should be fine because she has not gone through any sort of chemotherapy or other treatments that may impact her ovaries. So this is a scenario in which she could go through treatments that involve ovulation induction therapy. So some of the same medications that are used in that process that I described for ovarian or for egg cryopreservation, only instead of the goal being trying to harvest many eggs at a given time, it's really to get a single egg to develop and grow to the point that it reaches maturity, and then we can use medications to help induce ovulation and support the luteal phase of the cycle. In some of these scenarios, these patients may undergo IVF. So again, the first part, ovarian stimulation, but also after having that egg retrieval and fertilization process, she could go through and have an embryo transfer. So again, this is a scenario that may not necessarily require fertility preservation techniques, but rather fertility treatments to help after someone may have stopped getting their periods after going through something like cranial radiation. And then finally, I'm going to mention the case of a young woman who is prepubertal, or a young girl who's prepubertal with a recent diagnosis of a hamartoma. So this is a scenario in which really the only option may be potentially doing ovarian tissue cryopreservation, because in the prepubertal status, that is the best option. I also just want to put up this slide that has a couple of resources of different organizations that are great resources to go to if you have questions about fertility, and also specifically about fertility preservation, options for building a family outside of some of the techniques that we've talked about, including adoption, and options for psychosocial support as well. And this is a map that just demonstrates the Oncofertility Consortium. This has been a huge effort that was pioneered by Teresa Woodruff to really establish a network across the US and really across the world of different organizations and different centers that specialize in fertility care to help people navigate through this process at various junctures, whether it's at the time of diagnosis, post-diagnosis, in the surveillance period, or beyond, whatever is needed for these patients. And with that, I'm going to pause there and open it up to see if there are any specific questions that I can answer. There have been some great questions that have come through so far, so I really appreciate those. Is there anything else that I can answer for any of you at this time?